How about now?
Start with the definition of shock, which is widespread reduction of tissue perfusion, insufficient blood supply, and oxygen delivery to meet tissue demands, and there should be evidence of end organ dysfunction. All of these lines are important. First, it has to be a widespread reduction of tissue perfusion. Like if you clot off your femoral artery, you'll have a lactic acidosis and your leg will be white, but that's not shock. You have to have insufficient blood supply and oxygen delivery to meet tissue demands. So there could be two factors, the supply and the delivery are important. So some people have shock due to insufficient supply or delivery, and some people demands are too high. So that you could have a normal blood pressure, you could have a normal oxygen saturation, but still be in shock if your demands are high. And those are, sort of classic high output cardiac failures, pheochromocytoma, thyroid storm, and septic shock to some degree is to that as well, that your tissue demands are extremely high. And then you should have evidence of end organ dysfunction, which could be pretty much all the organs. Classically, it's divided into various types of shock, and I think it's whenever you see somebody in shock, it's tempting, and sometimes people even have written septic shock by the time you reach the patient, that it is a common diagnosis that we see. But you don't want to miss the other ones, which are very important and actually much more easily treatable than septic shock. So hypovolemic shock, cardiogenic, obstructive shock, distributive shock, and so-called cytotoxic shock, where the cells are unable to utilize oxygen normally. So like somebody who takes cyanide will have a normal oxygen saturation, normal blood pressure, but they'll still be in shock with an extremely high lactate and brain failure and a heart attack because their cells are unable to utilize oxygen. There's many other poisons that we more commonly see than cyanide. You see a similar thing with sometimes HIV medications. Metformin would be another one that can do a similar thing. Hypovolemic shock they're doing a resuscitation of somebody with hypovolemic shock right now. They're going to bring him to the ICU, I heard. We don't see a lot of trauma because we're not a trauma center, though you all do a month of trauma. So when we do see hypovolemic shock, it's usually our type of trauma, which is somebody was like stabbed in the femoral artery. And we see that a lot. If you had a cardiac cath, you might have been stabbed in the femoral artery, and that's the same as if you were stabbed with a knife with a femoral artery. So you might see hypovolemic shock from that. Post-surgical, this patient just had an IR procedure. They're trying to drain something, but he's bleeding significantly, apparently. Important, 10% of, we see after kidney biopsies, sometimes we see the same thing. That's the same thing as a trauma. 10% of blood volume, all you may see is tachycardia, 25% before you develop even orthostasis, and before you are going to have frank hypotension, you have to lose 40% of your blood volume.
Do they still use the classification class 1, 2, 3, 4?
Yeah. So the HTLS classification. So the last would be class 4. So 40% of your blood volume loss, at least for trauma cases. Though the rate of volume loss is also important. So I remember when I was an internal medicine resident that we had a 35-year-old man whose chief complaint, he came to the emergency room because he was short of breath while playing basketball. So that only when he was doing maximal exertion was he short of breath. They did a CBC, the hemoglobin was read as low, it was undetectable, and when they spun his crit, it was 9%. So he had been very, very slowly GI bleeding for a very prolonged period of time, and he was definitely not hypotensive. He looked quite well. He was walking and even doing regular amounts of exercise. He wasn't short of breath, but didn't have much reserve, I guess. Cardiogenic shock can be due to myocardial dysfunction or death, but all of these others really should be considered cardiogenic shock. A significant hemodynamically compromised arrhythmia, valvular dysfunction, or structural abnormalities. It's a leading in-hospital cause of mortality after MI. I guess if you don't get an assist device or a heart transplant, you have to lose greater than 40% of your myocardium, and usually a main coronary artery vessel has to be involved. With obstructive shock, the rate of development of obstruction is very important. Many patients have chronic multiple pulmonary emboli, should generally not be in shock, should not have right heart failure from that. What they will have is hypoxemia and pulmonary hypertension from chronic pulmonary emboli. If you develop cardiac tamponade, can occur acutely with 150 mLs of fluid. But at the same time, you might have somebody with uremia who has a huge pericardial effusion, 1 or 2 liters sometimes, who may develop a fluid slowly. And post-cardiac surgery, where we do see a lot of our tamponade, it doesn't have to wrap around the heart. It's deloculated and may be more difficult to diagnose. So though everybody knows this, that you'll get different patients, even by official echo readers, saying that the patient is not in tamponade, the fluid's too small, etc. Tamponade, of course, is a clinical diagnosis, but you can diagnose tamponade based on an echocardiogram. You have to see the patient and determine their vital signs. You can have echo findings that may or may not be consistent with tamponade, but you can't diagnose it based on the echo. And again, even small amounts of fluid, if it rapidly develops, especially from bleeding, you can develop tamponade quite quickly. Distributive shock, the most common one. We see a septic shock, but always think about the other ones. Adrenal insufficiency, very occasionally we'll see an anaphylactic reaction. I get called to radiology for an anaphylactic or anaphylactoid reaction. Neurogenic shock, such as spinal shock or the vasoplegia of brain death, and sometimes medication effect. When you have shock, yes? Oh, thank you. Thank you. Your body tries to compensate by redistributing fluid to the vascular space, cutting off renal losses, tachycardia, inotropy, redistribute perfusion to vital organs. So often the extremities will become cool, even if the core is maintained and warm, and optimization of oxygen unloading. And your body is able to sense this by stress receptors in the right atrium based on the size of the heart and how much they're stretched. It gets a sense of your intravascular volume. You have baroreceptors, you have vascular chemoreceptors. The JG apparatus in the kidney can do renin-aldosterone system when it notices a low effective circulating volume. And your medulla can sense it as well. And your body releases epinephrine, norepinephrine, renin-angiotensin, aldosterone, ACTH, cortisol, sympathetic nervous system is activated, heart rate will go up, blood pressure will go up, vascular tone will clamp down. The endocrine manifestations of shock are quite interesting. There's always a debate, steroids, in shock, should we give them to patients with septic shock or not? But if you just randomly check some cortisols on patients with septic shock, you're going to find all kinds of numbers, including really high numbers like 80, that the patient's just under a massive amount of stress, and this is their response to try to respond to the stress. Your body has its own epinephrine and norepinephrine. You'll see this very, very frequently, that the patient will have altered mental status, they'll be like there, but their blood pressure might be 120/80, lactate 7, and you go to see the patient, they're infected, and are they in shock? And the answer is yes, yeah, they are in shock. They just happen to have their own norepinephrine and epinephrine, but at some point those are going to run out, and their blood pressure is about to be 60/PAL. So be very careful when you go to see those patients. Blood pressure might be normal. It doesn't mean they're doing well. And some people use the term cryptic shock, for those patients. They give the patient any sedative, like let's go ahead and intubate that patient. You take away all that sympathetic stress. Immediately the patient's on high-dose pressors or sometimes suffers cardiac arrest if you're not too careful with that patient. And all of the end organs can be involved. Can be involved. Okay, so shock, like a lot of stuff we do in critical care, it's a medical emergency. So unfortunately, you have to diagnose and manage at the same time. So that you'd like to spend some time to think about what type of shock is it, and what's it due to, and if there's an infection, does the patient have Q fever? It's interesting, but you have to keep the patient alive long enough to get your Q fever test back. So must occur simultaneously. You suspect it based on tachycardia, hypotension, oliguria. Sometimes the only finding is encephalopathy, altered mental status. You see it in a hospitalized patient. Think very carefully about infection. And diagnostic and management. Have you been introduced to the adult severe sepsis inpatient protocol? Nope. Anybody on the consult service? It's too busy during consult. Oh, okay, yeah. So if you get called for a patient who has sepsis, then you should tell the intern or the PA, please order adult inpatient sepsis protocol. And that puts a lot of labs orders simultaneously together, and has a lot of advantages also, because you'll get that first dose of antibiotics within an hour. It's guaranteed to you, unlike most orders, which who knows how long they take. They're automatically approved also, no need for ID approval, if you use the recommended antibiotics for the type of sepsis that you're treating. And it even gives you recommendations if the patient has healthcare-associated pneumonia, why don't you try these antibiotics? You could change them if you want, but it gives you some suggestions. So if they haven't done that already, then recommend that they put that order set in. It'll save you a lot of time. So CBC, SMA7, lactate, coags, EKG, chest X-ray, and echocardiogram. And that would mean that you do it, because if you order an echo, even a stat one, it may take 15 minutes, which is too long. You have to get the echo much sooner than that, so you need that at the time of the evaluation. So there should be nobody who you evaluate for shock or hypoxemia who doesn't have an ultrasound and an echocardiogram that you do. These are recommended by SCCM guidelines, CVP, central venous oxygen saturation, though the abundant evidence says that CVP has no ability to determine whether somebody's fluid responsiveness. Upwards of 40 trials, so one of the most studied things. I'm not going to say I recommend you check CVPs on patients who are in shock. Central venous oxygen, there's some reasons that you may want to check it. It may help you with a differential diagnosis. Whether it's mandatory or not, you make your own judgment. It is important to have goals of resuscitation, and these are the goals that were established in the original Emmanuel Rivers trial, now a classic, on the early goal-directed therapy of septic shock. People have challenged it because it's a single-center trial, and now 3 multi-center randomized trials have not been able to show an advantage of this type of protocolized resuscitation compared to standard care. But I think the majority of people still agree that the concepts are there, and some parts of it have to be good. but exactly what parts is the challenge. But anyway, they wanted the mean arterial pressure to be greater than 65, the CVP to be between 8 and 12. Of course, we wouldn't use CVP. We would use measures that relate to volume responsiveness and assess those. Urine output greater than 0.5 milliliters per kilogram per hour. That's generally a pretty good one. That's a sign that the kidneys are being perfused. If you check an SVO2, they liked it to be between 70 to 80%. Keep the SAT above 93%. And then if you didn't reach those goals, like what if the urine output is not as good as you want, or the mixed venous was 40%, what are the things you can do? Well, you could give more volume, you could transfuse PRBCs, or you could give inotropes. All of those might improve the oxygen delivery. And this is the oxygen delivery equation. So the oxygen delivery is cardiac output times 1.34 times the hemoglobin times your SaO2 plus a tiny bit for the dissolved blood. So what you want to do is optimize oxygen delivery and decrease oxygen demand. So speaking of oxygen delivery first, cardiac output is equal to stroke volume times heart rate. So you take each individual thing and think, how could you optimize somebody who has signs of shock? First would be heart rate. Now there are some people who are in shock because their heart rate is 20. And how would you treat that patient?
Inotropes. Untranscutaneous patient.
Well, I would speed their heart rate up. Yeah, and that may be chemical or mechanical pacing, but you want to speed it up really quick because if they're in shock from a heart rate of 20, you better get their heart rate up pretty quickly. So prepare to pace the patient or give atropine if you think they'll respond, or give chemicals that will increase their heart rate. Then occasionally you have somebody who's, now most people who are like say in septic shock are at a heart rate of 110 or 120 sometimes, but sometimes you have somebody who has an indwelling pacemaker in, and they have significant sinus disease, and their pacemaker is programmed to a heart rate of 50. And then they have severe infection and septic shock. So what you do for that patient? The heart rate's like always 50.
Turn off the pacemaker.
Yeah, call the pacemaker police. Yeah, and tell them, why don't you try the heart rate at 80 and see if that's better. And then some of it's just empiric. There's some people the blood pressure will go up, some won't, but yeah, it's worth a try. Make the heart rate 80. Making it 140 is likely not going to improve the cardiac output. But 50 may not be enough for somebody who has severe distributive shock. They may need a higher heart rate to maintain their cardiac output. There's 3 physiologic methods of improving stroke volume, and what are those methods? Notice it says stroke volume, it does not say ejection fraction.
Augmenting the preload.
Yeah, augmenting the preload, decreasing afterload, or increasing contractility. Yeah, those are the 3 methods. So it's very important to assess the preload. If you think somebody's preload responsive, that's a medical emergency. You better bolus fluid wide open as fast as you can until you assess them as not preload responsive. But you want to have some objective measure of assessing that. And then some people have signs of like end organ failure because their blood pressure is 350 systolic. So you better drop that blood pressure. Most of the patients we see with shock have a low blood pressure with decreased afterload. And then some patients need inotropes. So if you know that, you may use inotropes. But bedside echo, sometimes you get surprises. Several times been called, somebody has multilobar pneumonia and intubated, and let's bolus fluids, etc. But you just do a bedside echo and the heart's barely beating. EF is 10%. You don't suspect it because it's a young person. They don't have a history of coronary disease, but you find that out. It takes a few seconds, and you might change the entire diagnosis and treatment plan. Okay, so there's your cardiac output. Then if you get a question on the boards, which of the following will increase oxygen delivery the most? Then giving 1 unit of blood or doing this or doing that, the answer is always transfusing 1 unit of blood. Do the calculation just to be sure. You don't want to get the answer wrong, but it's always 1 unit of blood because it has that 1.34 transfusion there. So definitely oxygen delivery is augmented by blood transfusions, but there's a price. The risks of blood transfusions the viscosity of the blood as you may give too much. So you want to be very careful. In the Manny Rivers trial, they went up to crits of 30, but likely that doesn't help most people. And just keeping 7 sick patients is good unless there's keep having severe signs of poor oxygen delivery, then you may transfuse up to crits of 30, but that would be a rare exception. Oxygen saturation, of course, is important, that you can't deliver oxygen to your tissues if it's not in your bloodstream. So you may have to give oxygen. And then oxygen bound to hemoglobin is delivered to your tissues much more effectively than oxygen in your blood. So that's why when we intubate people, we don't try to maintain a PO2 of 550. We try to keep it usually between 50 to 100 or so, because it's a very minimal increase in oxygen delivery there. Now, there's one exception to that rule. So when we want to keep some with PO2 of 550? Yeah, so that really, even there, what you're using high levels of oxygen for is to displace the carbon monoxide off the oxygen, off the hemoglobin, because it has a very high affinity for the hemoglobin. So you're trying to overpower it with a lot of oxygen. What did somebody else say? So you're just getting it sat to 100, but you don't need to get it to, PO2s of 500 or so. So usually it's for patients who are severely anemic. So if your hemoglobin is 2, and Dr. Dismangaitis wrote a little article about it where he did the calculation. You can pull it up on PubMed. And then you do the numbers, you'll see that then this actually becomes about 25% of your oxygen delivery. So if you have somebody whose hemoglobin is 2 or 3, then you might want to intentionally keep their PO2 at 500 or so. Most people whose hemoglobin is 2, you would just give them blood transfusions. So then it really becomes those patients who refuse blood transfusions whose hemoglobin is 2, which usually is Jehovah's Witnesses. And so occasionally we'll have a patient like that. All right, you should all read, certainly, the Surviving Sepsis Campaign. It's published in Critical Care Medicine, at least, February 2013. It's about 40 to 80 pages, but you can start with the executive summary, which I think is 3 pages. And they give consensus recommendations with the level of evidence behind them. And then you should also read this article. This is in the New England Journal of Medicine by Finfer and the Jean-Louis Vincent. And a very nice review. It's very clear. One thing I really liked, what he did is he just took a bunch of people who had shock from some trials. They were trying to enroll people with shock, with treatment, and said, like, if somebody just told you, this patient has shock, what is the most common ones that you see? And he found the #1 cause was distributive septic shock. So if you say, I have shock, 62% of the time, if you just guess septic shock, you'll be right, which is pretty good. So that's always a good thing to think about. Of course, 38% of the time you'll be wrong. So that's why you want to think about the other shocks. 4% were distributive non-septic, like anaphylaxis or true Addisonian crisis. Some percent of 10% cardiogenic shock, 10 to 15% hypovolemic shock, and 2% obstructive shock. So the least common cause of shock, but by far the most important one to recognize, because the treatment is so different for obstructive shock, and often the patient might do quite well if you determine this and you treat the patient. Though it's the rarest type, it's probably the most important one to recognize quickly if there's an obstructive shock going on. He has a little flow chart he says you should follow. Is the blood pressure low? Are there signs of tissue hyperperfusion? If there's no signs, there is a chance that the patient just has low blood pressure, 80/40. And you'll see patients like this who have cirrhosis or they're just very thin sometimes, young people. Patients with low systolic heart failure, may have a blood pressure of 80/40. The cardiologists like them to have a blood pressure of 80/40. They want it to be 70/30 if they could. So You have to have signs of tissue perfusion to be in shock. All right, then you have shock. All right, so is it a high or low output shock? They say to check a CVP, but it may help you somewhat in the differential of shock. It's not going to help you with the fluid management, unfortunately. And then they say, unless the cause of, if you read the text, he says, unless the cause of shock is extremely obvious based on history or physical exam, like the person had their arm sliced off and blood is spurting out of it, well, I would probably hold pressure. That's probably hemorrhagic shock. But if it's not that obvious, then the next test you should do is immediate echocardiography. So that's what he recommends. So that's what I would recommend as well. Put it off the New England Journal of Medicine. And he says that will help you right away determine, is it distributive shock, hypovolemic shock, cardiogenic shock, and obstructive shock. You could rule that out right away, certainly with an echocardiogram. And a focused echocardiogram. You don't need detailed hemodynamic measurements to do at least this part of it. And then, based on the type, then you could say, well, what do I do? Okay. Sepsis resuscitation bundle. Sometimes Dr. Kavedan will ask you, if you had this patient with shock, did you do these things? So yes, you should do these things, and this is in our adult inpatient sepsis order set. Serum lactate measured, blood cultures obtained prior to antibiotics, broad spectrum antibiotics administered within 1 hour, and you can see the very famous trial with one line showing that if you give antibiotics at 1 hour, 2 hours, 3 hours, 4, I think it goes up to like 12 hours. 12 hours later, let's give antibiotics. That the mortality just linearly increases. So probably the most important thing is broad spectrum antibiotics, the appropriate thing, within 1 hour. And then it says crystalloid bolus 30 mLs per kg. So that's the initial bolus. So for a 100 kilogram person, it would be 3-liter bolus. May not be enough. So that's the initial, and then you want to reassess the patient to see if they need more. Now this is sort of blind. Again, if you have judgment, you can see that, oh, actually, there's no sliding lung, and the right heart is dilated. They actually have a massive tension pneumothorax, and the treatment would not be 30 mLs per kg. It would be a needle decompression. So if you can make the diagnosis, you might be able to treat the patient. Very important to remeasure the lactate. So serum lactate is 6. Okay, that's okay, but then you do an intervention like bolus fluids and then repeat it. It should come down, or maybe you're missing something, or they need more fluids. And then corticosteroids for, at least by the SCCM guidelines, what's called pressor unresponsive septic shock. They don't define it too well, but they say that you should give corticosteroids. And interestingly, they say 200 milligrams a day for patients with pressor unresponsive septic shock. They recommend against doing an ACTH stimulation test, and they recommend against checking cortisol levels unless you think the patient actually has adenosine crisis. Then you should check the cortisol level. And you can check this website also. It's a living website, survivingsepsis.org, about the Surviving Sepsis campaign. All right, so, any questions in general before we get to the cases? All right, the cases. So, who's going to go first?
78-year-old woman presented to the emergency department with fever, dyspnea. She is intubated, chest X-ray shows ET2 inflate and a left lower lobe infiltrate. After 6 liters of crystalloid over 3 hours, BP is 80/40, hematocrit is 32%, and MVO2 is 55%. What should you do next? Should do an echo.
Yeah, you should do an ultrasound, and then for several reasons. One, and you may have got these readings as part of the pre-coursework for ultrasound course, and did they put the fellows yet or not yet?
For the 3-day course?
Yeah, not yet.
Yeah, we got.
Oh, you did get it? Okay, yeah. So yeah, if you read some of the chest articles, you'll see how is echo useful for people with shock, and you'll see the sort of 5 ways it might be useful.
I think she can
Making sure that the blood pressure number is accurate.
Yeah, absolutely, yeah. So let's say you don't know if that's real. How would you find what the real blood pressure is? Yeah, but unfortunately, they don't put them in the emergency room. And if you did put it in, there'd be nothing to transduce it with.
Yeah.
They don't have the modules.
Well,
Yeah, so you could check it manually. And then even better than that, of course, you'd put ultrasound on. So you put an ultrasound over the Doppler, the brachial artery, and inflate a blood pressure cuff over it manually. And then when you abolish the Doppler signal, that's your systolic blood pressure. And so that's probably the most accurate, non-invasive way of checking somebody's systolic blood pressure. So I would recommend doing that. Sometimes you have trouble. People, can't quite, is that a real blood pressure or not? Just put the Doppler on, and then you'll get the systolic blood pressure. Then, would you do anything else for the patient? Yeah, I think start pressors. Yeah, that goal is mean arterial pressure of 65. It seems to be lower than that. So I start levofib, titrate to mean arterial 65. Okay. And then the echo also will help you is maybe there's another type of shock, or maybe it's a mixed picture, that it's septic, but also there's cardiac dysfunction at the same time. Not too uncommon. And give antibiotics. And what antibiotics would you choose?
I would go broad spectrum because she's very sick. So, possibly Benzos and a Zithro. I mean, I'm not sure if she's coming from home or if she's coming.
Yeah, so you want to differentiate between, you want to ask several questions when you're choosing antibiotics. One is, who is the patient? Is she immunocompromised in some way? Is she neutropenic? Is she, does she have, is she from a healthcare system, or is she from home? That will help you choose. If she's from a nursing home or has been hospitalized and on day 5 she develops this, then you want to treat very broadly. So often we use, say, Vanco and Zosyn, and then consider Legionella coverage as well with azithromycin. And if she's from the community and she has no risk factors for resistant organisms, I usually don't give Zosyn to those patients because it's quite uncommon to have Pseudomonas acinetobacter, so I would just give ceftriaxone with a Zithro. But I do give Vanco because there is community-acquired MRSA and patients who are sick enough to be critically ill and shock in the ICU. So if she was from the community with no obvious risk factors, I'd probably give Vanco, ceftriaxone, and a Zithro. And if she were from a nursing home, Vanco, Zosyn, Zithro as well. Now, but that's the minimum. What else do you need to know about the patient before choosing antibiotics?
Allergies.
Yeah, allergies. That's good. Yeah.
Renal function.
You need to know, well, renal function actually doesn't play a role to the initial antibiotics. Yeah, that, so even if she has no urine output at all, the initial dose of, say, Vanco has to be 20 milligrams per kilogram and to load up the system. So if she's 200 kilograms, then she needs 4 grams of Vanco in the first 24 hours, even if she has no urine output at all. So a common mistake is that they'll get a gram of Vanco and let's check a level tomorrow. But that's not going to be good enough for somebody who's 200 kilograms. So renally, so the initial dose, you have to get the medicine to the body, and then it can be excreted. It just changes the frequency of dosing, not the initial dose. You have to know, has she had infections before? So you go to the microbiology and CareCast and go back 2 years and see, has she had resistant Pseudomonas that was only sensitive to meropenem? Well, then it would be a mistake to give her Zosyn. So you have to look back to what the prior cultures show. And then what season is it? Is it influenza season? We have a lot of influenza when it comes to wintertime, so you want to check that as well. Has she traveled anywhere? Does she have MERS? So you got a couple things you want to know. All right, so you start some pressors, and then additionally, you want to recheck the fluid status. Is 6 liters enough? Maybe she needs 7 liters. Maybe needs more fluid. We'll see. All right, next one.
68-year-old man is in the emergency room department with altered mental status, tachycardia, tachypnea, and blood pressure of 74/33. Normal saline is started wide open. After 10 minutes of blood pressure is 60/32 with no improvement. Can you be responsive only to pain? What should you do next? Okay. So he's hypotensive and he's responding appropriately with tachycardia, tachypnea. So if he's having altered mental status and response to pain, I have to worry about his airway. So I may consider intubating him at this point.
Yeah, I think he's going to need to be intubated. The only question is, how are you going to intubate this patient with him not dying in the next few minutes while you intubate him?
May do awake sedation with him. I want to do the complete general anesthesia with maybe just lidocaine and Versed.
I mean, if he's still breathing, can you try to improve his hemodynamics a little bit first?
Yeah, that would be ideal. Ideally, you would sort of break into two teams, because at any moment he might stop breathing entirely or fluids, but if you can get a little more fluids into him, you're definitely going to be better off. So keep bolusing fluids through multiple IVs simultaneously, and meanwhile, set up an ambu bag, intubation tray, etc., and get ready. Then
central line.
Yeah, and then central line if possible. Pressors you might think about if you have time. We have intraosseous as well, which is much faster than putting in a central line. Put it in a few seconds, especially if the patient's really unresponsive. Awake people, have you put them into awake people intraosseous? I have. Yeah.
I've done it.
Yeah. It's not very pleasant, yeah, and the problem is it's not just the drilling that's unpleasant, but every time you infuse a medication through it,
that's what's
extremely painful. So it's like doing repeated bone marrow biopsies on people,
kind of cool.
So I do try to avoid it in awake patients, but if you have to, you might have to. Yeah. Would you start pressors on this patient?
If you can, peripherally, you can start dopamine. If you want
dopamine is considered contraindicated, so that's not a pressor that's really used for most forms of shock. Now, sometimes we will use dopamine for the sole practical reason that it's in the code cards. So if you're on the floor seeing a patient, it might be there, so you can have it. And meanwhile, you should order Levophed from the pharmacy and have it there. But if you're in the emergency room or the ICU where you have Levophed, there's very few indications where you would actually use dopamine on somebody. You would use Levophed. And then the question is, can you run Levophed peripherally?
Yep.
Yeah, absolutely. Yeah. Can you run dopamine peripherally?
Yep.
Yeah. Okay. Can you run phenylephrine peripherally? Yeah, absolutely. What is the risk of doing it?
Invasive surgery later.
Yeah, that if your IV's not too good and it extravasates, you're going to have a white arm and necrosis. But on the other hand, the risk of the patient coding, because the blood pressure is falling while you're bolusing fluids, is quite high. So I would start Levophed at this point while bolusing fluids simultaneously. What about, some people say you should not give pressors to people who have hypovolemic shock.
That's most correct. I mean, low dose Levophed first, that's what it does. It will increase your preload by decreasing the venous size. So essentially, you do an auto, infusion of fluid without actually giving fluid, and you can use it for your advantage because if you were wrong and they were not quite hypovolemic, you can always turn it off and
Yeah. Yeah. I would agree with you that. That it has some effects you describe it. It is sort of bolusing fluids, actually. Yeah. And additionally, the treatment is going to be fluids, but sometimes the patient's dying so quickly that you don't have 30 minutes for the fluids to run in. You just have to keep them alive while the fluids are running in. And hopefully you run them in and you'll be able to get to lower doses of Levophed. Now, what should you do if, let's say, you started it and Levophed turns out and the arm is turning white? What should you do? Yeah, try it somewhere else. I'd agree. You want to save that arm?
Question. I mean, will you inject phentolamine or whatever it is?
Yeah. So that's recommended. Yeah, and at least in case reports, it has effect. So you inject it not intravenously, because you don't want to lower the blood pressure, but you take a vial of phentolamine, and you just draw in a syringe, and you inject it like with a TB syringe, sort of in a circle around the site. Some people use nitro paste as well locally, but phentolamine probably makes the most sense because it's obviously an alpha blocker. But definitely can be running peripherally. That should be for a short period of time, and for 10 minutes while you put an IO in or a central line, and then just switch it over. But in this case, I would start it, and then I would get the blood pressure up enough with a combination of fluid and levophed that it's safe to intubate the patient. You said you think about maybe we should intubate the patient awake or with only a little bit of Versed, and to try to avoid dropping the blood pressure. But be careful, even if you use no sedation at all, and you intubate the patient may still drop their blood pressure and suffer cardiac arrest. And why is that? Yeah, simply the positive pressure ventilation. Even bagging the patient, they may suffer cardiac arrest. Whether or not I'm giving any sedation, or I'm giving any type of sedation, or etomidate, which maybe that doesn't drop your blood pressure much, or ketamine, which maybe has some sympathetic response, or nothing, I still start pressors, get the blood pressure up to over 100 systolic before intubating the patient. And you notice even when blood pressure, that patient's blood pressure intubating today is 180 systolic, I still have the nurse bring vasopressors there, load them up in the line on a pump. So in case the blood pressure does fall, I don't spend a minute raising it. I turn on immediately.
Have you even pushed those pressures of like levophed or only epi or phenylephrine?
Only epi or phenylephrine. There's no particular reason I guess you couldn't give levophed boluses, but I personally haven't done it. Phenylephrine is in all your kits, so you guys will have it with you when you do consults. Epi's in all the code cards, so sometimes they'll give 0.2 of epi, something if I need to get it up quickly, even if the patient's not coded. All right. And number 82.
An 82-year-old man presents in the nursing home. He has a PICC line in place with purulent discharge. He's receiving infusions of naphthalene for Staph aureus bacteremia. Recently completed treatment for Klebsiella, healthcare-acquired pneumonia. He has a trach and a PEG and is mechanically ventilated. Heart rate is 120, BP is 110/70. Lactate is 7. What should you do next? So I think this is a classic situation where you should be starting on fluids immediately.
Yeah.
The PICC line needs to be sampled before it's pulled to get a good source outside of other source investigations. And then,
but it's very important to pull it quickly. So you want to put out alternative access, pull it. If anything's going to help the patient, is pulling that purulent PICC line out of his body. What antibiotics would you choose?
So for him, I'd have to look into the system to see exactly what he would get an MDR Klebsiella or not. Either way, vancomycin.
Yeah, so Klebsiella, you want to treat at least for what you know they have.
Right.
But probably broader than that. If he's been on naphthalene for a while and now he's septic, it could be a more resistant organism at this point.
And also review his medications. Lactate 7 might be a medication. It could be type 2.
Yeah.
Not necessarily. I mean, it sounds like clearly it's what we're discussing. But
yeah, it sounds like he has pus coming out. It's probably septic shock. We always think of something. How do you know he doesn't have ischemic bowel? And that's why it's lactate 7.
I don't yet, but after my physical exam, I'll have a good idea. And
You could have gotten a bunch of albuterol treatments just before that as well.
Yeah, there's a lot of causes.
Tachycardia, lactate up.
But particularly, I want to know if he has ischemic bowel because he'll die if I don't take him to surgery. So I need to know that right away. So how am I going to find that out?
Exam, guac, and
How right away? Like within how soon? Like
I need to find out within the next hour whether he has ischemic bowel.
Emily? You can.
Yeah. Well, I would bolus some fluids, so that try to resuscitate him, and give him 30 cc's per kg of fluids, assess his volume status, and then repeat the lactate. If the next lactate is 2, then he probably was in severe shock and got fluid resuscitated. If the next lactate is 9, despite my resuscitation, then I'd be quite worried that he has a ongoing cause of lactate production that's not responsive to standard resuscitation. So lactate clearance is extremely important, especially if you're worried about focal production of lactate. That otherwise you would expect it should respond to general resuscitation. So that's something very important to repeat. At 7 is good. That's, you know, it's good to check it, but is it getting better or not? If it's not getting better, you have to broaden your gaze. All right. Should he come? Yeah. Yeah. Huh?
I know we used to do it a long time.
Huh?
We used to culture the clips. We don't do that anymore, right?
Yeah, it's basically, it depends on the case. You know, if you think the patient has a fever, they have a line in, I'm just going to take it out. I usually don't culture the tip because I'm just taking it out, I'm going to put a new thing in. If somebody has pus dripping out of it, and it's like obviously is the source, then I do. I just take it out and snip it. Exactly. Yeah, exactly. Yeah, in case it's now maybe has MRSA, you know, it might help you, you know, with your antibiotic choice. Okay, so.
Anton was asking, how soon do you check the lactate after you're giving fluid resuscitation? So you check it like after an hour, after 2 hours, after 4 hours?
The key to the early goal-directed trial is you choose an intervention you do, and you see the effect of it. So you do an intervention, I want to see the immediate effect of that intervention. So if I say the urine output, the reason I bolused fluids was because the urine output was only 10 cc's per hour. I'm going to bolus fluids. 1 hour later, is the urine output better or not? If I'm bolusing, if I'm starting inotropes because the heart wasn't pumping too well, I'm going to start inotropes, dobutamine, 5 mics per kilo per minute. I better repeat the echocardiogram. Then the way the anesthesiologist does it in the operating room when they do a TEE, and how's the heart beating now? Better? Okay. Not so much better? Well, I better increase the dose of dobutamine and try again. Or if you're following a mixed venous or a lactate, start the dobutamine, check those, and then increase the dose. And so you have to immediately, whatever intervention you do, you should immediately see the effect of it. And that's the difference between the things that we're doing for monitoring focused echocardiography. Now you should still get formal echocardiograms because that gives you a lot of information, hemodynamic advanced measurements. But try ordering a full echocardiogram Q1 hour for 6 consecutive hours. They probably won't do it, or you know that. Yeah.
Will you try to do 4 liters first and then repeat like?
Well, you choose an intervention that you think this is the intervention I need to help the patient. You know, is it a fluid bolus? Is it dobutamine? Is it a blood transfusion? Whatever you think they need to do. The intervention's over. Immediately, what's the effect of it? Because 4 liters may be enough or maybe not enough. Maybe you need 2 more liters. All right. And the last case.
Status, heart rate is 20, blood pressure is 50, systolic temperature less than 80 degrees, respiratory rate is 6, patient is unresponsive to queen, EVG shows pH 6.8, PCO2 55, PO2 50, light heart less than 6, lactate 20. What should you do next? Should it be the thing?
Yeah, I would agree with you, yeah. The patient has a combined metabolic and respiratory acidosis. The thing you could fix the fastest is the ventilatory issue. So intubate maximal ventilation is indicated, I would agree.
Warm them up.
Warm them up, yeah. And do you want to do passive warming or active warming? Yeah, because the patient has significant hemodynamic compromise, bradycardia, you know, ... So you want to do active warming maximally. So how would you warm this patient?
Warm fluids, Arctic sun, maybe even consider lavaging.
Yeah, warm fluids, saline.
Yeah, it has to be internal warming. So you can take bags of saline, put them in a warmer, bolus them as rapidly as possible with the minimal amount of tubing on pressure bag so it doesn't get cooled by the room air into that. And you could do other things. Yeah. Well, warming blankets are generally not indicated for this. So it's active internal cooling. You actually, there's reasons to think you don't want to warm the periphery. that may vasodilate and actually, take things away from the core. So everything should be active and internal, basically. So what they did in the emergency room, they're very aggressive. They did put bilateral chest tubes in, as well as a peritoneal catheter. So they put a peritoneal catheter in and lavaged warm saline into the peritoneal space, as well as both bilateral chest spaces. There's other ways to do it as well, as you said, that things like the Arctic sun, which we used to cool, you can try to heat people with it, or intravascular catheters, or CVVH, or ECMO, or bypass machines are effective as well. Okay, so active warming. What else?
And fluid resuscitation.
Yeah. Yeah, fluid resuscitation, which would happen to be warm.
And the heart rate is also very low.
Yeah. Yeah, I'd pace the patient. Yeah. So start with transcutaneous pacing. May need a transvenous pacing. May or may not respond to pacing because there's so many problems with this patient. Bicarb of less than very acidemic, etc. So you may have to correct the pool and the thing, but I would start trying to pace the patient. Yeah. It's gonna depend. Yeah, exactly. Yeah. I think if you're going to use a bicarb drip on anybody, when the pH is less than 6.8 and the bicarb is less than 6, you might consider it. But again, yeah, as you know, there's not too much evidence that it's beneficial.
With a heart rate of 20, I hardly think that she's going to have a peripheral pulse, so we should initiate CPR.
Yeah, it's a good point. Yeah, the blood pressure is 50 systolic, so probably doesn't have palpable pulses, I would guess. So even if there is some cardiac activity, so basically you could start the ACLS algorithm. Probably she'll benefit from chest compressions and epinephrine. Yeah, I would agree that the cardiac output is probably so low that chest compressions would raise it. Yeah. So I would agree. All right, and intubate, as you said, yeah, admit to ICU, I guess. Yeah. All right, and what do you think is going on here?
Was she found on the street or at home?
In her home. Yeah. And it wasn't like 10 degrees in her home. Yeah, so it's normal temperature in her home. Yeah, so this would be a very good case for a mixed edema coma, or mixed edema coma plus an infection, maybe that tipped it over. Bradycardia, hypothermia, etc., altered mental status. Yeah, such a classic case. I would check TFTs, I would check cortisol, and I would replete them. So I would give this patient IV cortisol and IV levothyroxine. Should just be one dose by the time you get the results back, but it's so suspicious that it could be, and it's life-threatening, obviously, that I would actually start giving them to this patient. Very uncommon to see this amount of bradycardia with shock and hypothermia. So, okay, is there other things it could be besides endocrine failure?
Sepsis.
Yeah, sepsis is possible, and I think I would give this patient antibiotics. Yeah, she's sick enough. Whether may not have an infection, but certainly possible.
Cardiogenic shock from severe.
Heart rate 20, is why there is no T wave or T wave.
Yeah. Yeah, is it heart block? Is she hyperkalemic? Renal failure, could present a lot like this.
But it would be best to warm the patient up. A lot of times you can have a lot of bradydysrhythmias just with severe hypothermia.
Yeah, the hypothermia could by itself, that's why active warming is indicated for the hemodynamic thing. So let's talk about the 5 types of shock. Could she be hypovolemic?
Yes.
Yeah, she could be. And you said you're going to give her some warm saline. This can't only be hypovolemic shock. Yeah, there's no particular reason her heart rate should be 20 if she has hypovolemic shock, or that her temperature should be less than 80 degrees, for example. But, okay. Could this be cardiogenic shock? It could be. But again, there's a lot of other things that seem to be going on. I bet her heart is not pumping very well at this moment, but whether that's from heart problems or severe hypothermia or severe acidosis or hyperkalemia, we understand. And distributive shock we talked about, septic shock, but also could this be myxodematous coma? Could it be adrenal insufficiency? Could she have obstructive shock? Yeah, it doesn't seem to fit, with all the major, hypothermia and things like that. Yeah, so it'd be good to, do an echo, of course, but unlikely. And then could it be cytotoxic shock?
I mean, with cytotoxic shock, your vitals should be that poor, like your heart rate. I wouldn't expect it to be that low of a blood pressure.
Well, what is the definition of cytotoxic shock?
Simply having uncoupling of oxidative phosphorylation.
Your tissues cannot undergo oxidative phosphorylation, so like something like cyanide poisoning, slate toxicity, and those affect every organ. Every organ needs oxygen, so if you don't have any oxygen that your tissues can use, then your heart can't beat, and you can't generate any heat. Mostly from skeletal muscles can't do anything because they can't use oxygen. And it'd probably be pretty acidemic, and you won't breathe. And your lactate will be high. The highest lactates you'll ever see are going to be in poisoning cases. Extraordinarily high lactic acids, because all you can do is anaerobic metabolism, basically. Okay. So what are the, should we give her the Eli Lilly cyanide kit? She
found in our house. So it's fine.
Trying to kill us cyanide. Yeah.
Good. She was in our house.
Yeah.
It was no mention of like a fire or anything in the house or somebody poisoned her.
Okay. Yeah, it could be metformin. Yeah, think about the most common toxins that we see are the toxins we give the patients. So those are poisons. So we rarely see very exciting things like cyanide toxicity. More commonly, we see that patients are poisoned by their own medications. Insulin, metformin, Coumadin. Those are the toxins that we see. And she has a history of diabetes and renal insufficiency, so those are the patients, especially if her renal insufficiency got worse, will have the severe lactic acidosis for metformin. Okay, so yeah, that was the case. It's cleared by dialysis, so she got CRRT, which was an effective way of heating her as well, though they had heated her up maximally in the emergency room already. She did quite well. The labs looked pretty bad, but she made full neurologic recovery. Just ended up needing permanent dialysis. Was the only thing.
So what was the culprit for her?
Metformin.
Oh, metformin overnight.
Yeah, it was a good thought. Yeah, that. And when you see an unexplained lactic acidosis, review the medications very carefully. This is the patient who will have it. Yeah. She had baseline creatinine was like 1.4, where in fact metformin was contraindicated because in her age and with that, his creatinine clearance was a little less than 40. But then she got a bisphosphonate, and her creatinine went up to like 6. She looked like this. All right, so that's it. Any questions? All right, so let's get back to work. Thank you.
Well, I'm going to send you instructions on how to record the lectures. We're going to be recording all of them. Okay. I recorded this one tomorrow. It'll be a second year to help explain it again. Fun.